Right, so welcome to PEM POCUS UK for this month, guys. Oh, I'm getting a transcript. I'll take that off. I don't need that. Good to see everyone. So for those who've never attended, this is a monthly CPD session that we do. Please feel free to chip in, ask questions at any point. It's an open discussion, so feel free to do that. We've got our videos from each session go online. So the recorded talks, as well as some short videos that I've done that might be educational to some people. So you can check them out on the YouTube channel. So I thought I'd do some cases this week from things that we've been kind of involved with in the PEDS emergency department, and hopefully illustrate some novel applications of POCUS or some better known ones with a bit of a twist and how it enhanced patient care. I'll try to keep an eye on the chat, so feel free to chip in as you need to. Okay, so our department got a 5 a.m. pre-alert for a 15-year-old female who'd been involved in an RTC. So I'm sure for any of yourselves who are working in the department or registrars, for example, this is probably not the kind of thing you'd like in the early hours of the morning. So this was, as I say, overnight. I wasn't involved at this stage, and a young girl in the family had borrowed the family car and decided to crash it into a house. The other information is that they'd self-extricated themselves and were ambulatory, but there was significant damage to the vehicle. And everything that's documented within the notes is documented exactly how it was written, either the observations or the wording, just to give you a feel for how it was at the time. So the registrar who'd assessed the teenager had done a really good job from top down, ventilating in air. They were breathing normally with no evidence of any sort of significant chest impairment or ventilatory requirement. But they were quite pale and fairly peripherally cold to the upper limbs, neurologically fine, but the concern was in relation to a very tense, tender abdomen throughout, really, with no obvious bruising or marks or abrasions. So obviously the registrar managing them had undertaken that ABCD assessment and had undertook some imaging, and this was predominantly of the CT of the abdomen and pelvis. And this was what he got back. So this is around about 6:30 in the morning at this point. And one of the points I just wanted to illustrate in relation to today is that presumably none of us on this call, certainly not myself, can reliably interpret CT scans. You know, I think if we know what we're looking for, we can get the idea probably there and around the spleen region that something's not quite right. But certainly I couldn't reliably make big decisions based on the need for theatre, the need to transfer a child from a trauma unit to a major trauma centre, for example, on the basis of CT alone. But what I can do fairly reliably, fairly readily, and in a repeatable fashion is interpret, obviously, ultrasound images. So I arrived at the department at 8 a.m. and I was hoping to actually do a simulation session. I came in a bit earlier to run through and set up a sim. And I actually had a real life sim in my department when I met this girl who by this point had slightly waning numbers. We had a bit of a neonatal looking blood pressure. We were tachycardic. You know, anyone who works in pediatrics knows that when you see a heart rate in this region, certainly above 100, for a teenager, not for a baby or a child, you know, this should automatically kind of, you know, make you take note. And this girl was much quieter. She wasn't talking. She didn't look great, to be honest, by this stage. This again is copied and pasted, exactly documented how I did it at the time. So I put a probe on and had a little look around. I was happy with the lungs. In the right upper quadrant, there was a positive sign for free fluid in Morrison's pouch. I've underlined the spelling of Morrison's there. I don't know if anyone's aware that everyone's been spelling it wrong for forever, basically. It's not 2 R's, it's actually 1 R. So if anyone didn't know that, the guy's name was James Rutherford Morrison with 1 R. And he actually was from our region, the northeast of England, Durham area. So I just thought I'd put that in as a little bit of an aside. One of my EM colleagues told me that this week. And the left upper quadrant looked grossly abnormal. I couldn't find any fluid down below in the rectal uterine pouch. but I couldn't do sort of a good subcostal view, secondary to where the pain was. What was really interesting about this girl is at this point, she was very distracted by all the rest of her injuries. She was in a lot of pain. But I did a bit of a sort of secondary survey using ultrasound, and we picked up quite an interesting wrist fracture, which I think if I hadn't have seen it on ultrasound, I don't think it would have been, well, it wasn't picked up clinically, put it this way, when the initial person assessed the patient. So it's quite nice. I was able to just sort of scan up and down kind of arms and relevant areas, and we picked up a fracture. So we put her into a cast. But I was obviously worried about the free fluid. So these are the images that I got. Just tell me if they're not playing all right. So they're both of the right, I'm afraid. I didn't manage to. I did save her left upper quadrant image, but we lost it when the machine went to be repaired, and I've been trying to hunt for it all this time. But she had some free fluid right and left. You can see here we've got this anechoic hypoechoic region here between, obviously. I was just checking that there's nothing in the chat because I've got a little alert, but that's fine. If anyone wants to say anything, just put it in the chat. So yeah, we can see obviously the free fluid there, which was a concern. Now we've got a girl who's been involved in a significant RTC who's kind of cardiovascularly less stable than she was. We've got some obvious free fluid definitively there in the abdo that I can reliably kind of make a decision on. And what happened there was that nearly 3 hours later, this was the report that we got on our CT. So it's all well and good ordering the CT. It's all well and good, having an initial look. But actually, if you're making a decision about whether you transfuse this child, activate the major hemorrhage protocol, transfer the child immediately to a major trauma center if you don't work in a trauma center, I just think, we're not trained to be able to interpret CT scans, and they're really complex. You're looking in 3D. I commonly look at them and think that I found something, and then it's actually, either a normal part of sort of bowel or mesentery or something like that. So with POCUS, we can make that decision. Remember, we're not comparing POCUS against cross-sectional imaging like CT. That's not a reliable or fair comparison. That's not what it's there to do. It's there to extend your clinical examination in a way that you can integrate your findings to then decide which imaging, if at all, you might need to do, or any clinical interventions that you need to do from repeating. So I thought that was quite an interesting one. As a trauma, because I don't work in a major trauma center, and we don't see a lot of sort of really significant major trauma, although of course most major trauma we know from the data will kind of be scooped and ran and present into its local center. But when you do work in an MTC, you probably have much more of a formulaic pattern of how you kind of pan scan effectively everybody, if there's any clinical concern at all. So I think it's nice to be able to undertake POCUS assessments fairly regularly, which I do. Okay, so my next case was a small 12-day-old baby boy, and he'd had some vomiting for around about 4 to 5 days, fairly significant, but non-bloody, non-bilious, and the child was entirely well, completely, doing everything as normal other than the vomiting. Looked well hydrated, had normal observations. So by way of mentioning in the chat, what do we think people might be thinking at this stage, or what might they do? Would you be concerned? Would you not be? Nobody be shy. Anyway, it's a common scenario, right? So we'll see these babies quite a bit, and yeah, it's an ultrasound talk, so there's going to be something interesting going on, isn't there? Thanks, Louise. So this would be really common and could easily be nothing at all, right? So I was thinking, yeah, this sounds completely fine. The baby looks fine. We're only 12 days old. However, I then got told this. He had an older brother. Older brother had an operation on day 20. So I thought, fantastic. So let's scan him. So at this point, I asked for a gas just to see where we're at with that. Everyone remembers what we're looking at for that. So typically a hypokalemic, hypochloremic metabolic alkalosis. We normally have that bicarb that ends up going through the roof as a sort of a kind of a counter reactive kind of mechanism to balance the kind of ions, but everything was fairly unremarkable. And that's, only 12 days. And there's a lot of evidence, particularly with the hypokalemia side, that takes about 2 to 3 weeks of symptomatology to become a problem. So I did a scan, and this is the scan. So I'll just talk you through the anatomy. I don't know, hands up in the chat if anyone's ever seen scanning for pyloric stenosis. I know it's a little bit out of the realms of the sort of normal kind of range, but in essence, it's something that I've had some extra training to do, and I really like to do it. So we're using the high frequency linear probe. We've got the probe marker to the patient's right, corresponding with this GE logo. And then obviously we're looking at the liver, sort of the medial aspect of the liver, and the kind of gaseous pattern of the stomach is going to be adjacent to that. So we can just begin to see here the sort of gas shadows of the stomach. Now, if we get this beautiful appearance here, a very, very prominent pylorus, which is like, looks like a cervix almost, with the clear outlines of the muscular walls and the mucosa and everything, then that's great. But often we don't. There are some measurements that I'm going to talk you through that we do, that I did in this case. You can see it here, but I'll take you through it in a bit more detail. So what I typically do here is I'll warm the gel as best I can. I'll have it in my hand for a little while, in my pocket maybe for a few minutes, just so that the infant's settled. We can sometimes settle them with some sucrose, just have them in the carer's lap, or if they're more settled on the bed. And then I tend to scan in this sort of region. So you can see this corresponds to the right side of the patient with the liver, with the stomach to the left, either in a kind of what would be a long section orientation to the pylorus, because obviously the pylorus is coming off in this sort of direction, or rotating into a long orientation, which would be transverse, looking across at the across at this sort of pylorus in kind of a circular 3-dimension like that. It's a bit of a dynamic scan, so I go between the two, but for measurements, it's obviously good to be on axis and know how you're doing it. And these are the sort of the labeled sections that you're looking at. So this whole area is the pylorus feeding down into the first part of the small bowel, with all the gastric content here, which will be a mixture of air artifact and obviously fluid. Sometimes you can do it directly while infants having a feed. It's nice if you can see that content move straight through the pylorus with the gas bubbles. That would be probably reassuring from my point of view for a negative for pyloric stenosis. So then we remember this equation, we remember this pi, sorry, 3.1415 as the first digits of pi, and that corresponds to the measurements that you take. So it's the outer wall muscle thickness, which is this hyperechoic region here. Sorry, the yellow, pardon me, which would be 3, should be single muscle thickness less than 3, and typically around about 2 or less for the ones that are normal. The overall width is the sort of olive measurement, which is the 1,4, which can sometimes be hard to get actually to be exactly right. Sometimes radiologists can get it bang on as a perfect sort of circular pattern, but it can be a bit tricky. But then the really most sensitive measurement of all, the one I like to do, is the length. So looking from the kind of gastric content here all the way down. And again, we're looking at 15 millimeters or more. The positive ones I've had have been really much more than that. And a normal range, again, it can be depending on the age, but it can be, no more than 12, 11, 12, maybe 13 absolute max. So this is another example of another one, which with, you can either plot it as a broken line, or you can just do a general overall line. You can see that it's way bigger than, way longer than normal, but also much more prominent. So this will be a really established kind of one that needs to be operated on. And then there's another sign that we can see, which is this protrusion of the antrum here, and it pokes out. It's called the antral nipple sign. And again, if you see that, that's highly indicative of a positive scan as well, where it's beginning to kind of protrude through and cause a bit of backwards pressure. None of the stomach contents able to exit through the stomach as in a normal fashion. Any questions about any of that so far? Anyone like to ask anything, or anyone came across anything like that, ordering pyloric stenosis scans from PED? Okay, so next case was I was in PED one afternoon, and one of the junior docs asked me to look at a 12-month-old boy with a lump on his head. This case you might be familiar with. It's in the on the YouTube channel. We did a short talk about this. And this was a very well-looking, just gone 12-month-old lad. He was entirely fine, and his parents had basically noted a shallow but quite diffuse in terms of size lump on the kind of parietal aspect of the skull. So I said, of course, I'll have a little look. I came along and I examined, and I did find a sort of diffuse shallow lump. It felt kind of fluidly filled, but I wasn't really able to infer anything at all, as I'm sure none of us would be using examination alone. So I did what I would normally do, which was to extend the clinical examination using POCUS. So I had a bit of a look. And yeah, as I say, it was well, infant was well, doing everything fine. And this is what I found. So what do we think? I said to the parents at that stage. Yeah, absolutely. Absolutely. So just straight away said there and then to the parents, I said, this is a fracture. Um, because I want, we needed to be upfront about it, and everyone on this call can see what I was seeing, right? Which was sort of obviously some hematoma above it with some sort of hyperechoic material, but ultimately, cortical deficit, clear fracture, right? So I told the parents that we needed to do a scan, and I went to my local friendly radiologist. This was actually, it was a locum who was working this day. And I said, this is the story. We've got an infant with a skull fracture. And they said, what is it? A bit boggy? Is, all of this? And I said, no, not really. I said, but it's there on ultrasound. And I got a really interesting reply, which was this from a radiologist. Not the normal radiologist I deal with, but I got this response. So I thought that was really interesting. I says, oh, I assure you. I said, I assure you. I said, I assure you, you can. You can, look up some of my publications if you want to, but basically, what have I been doing for 3 years? Looking at fractures. So I was like, okay. So I had to kind of negotiate a bit. I said, honestly, this is, an effectively non-mobile child, a child who's just stood, able to cruise and stand effectively. Clearly, NEI is very top of our list. So I said, we need the scan. So we got the CT scan, and I said, in the back of my mind was this beautiful paper from the EMJ, which was a really nice, significant patient number systematic review that concluded that actually, its performance criteria looking for fractures is actually really good. So we got the CT, and there was the reconstruction, and there was the fracture, the swelling. So, you know what it's like when you're the senior on and you're involved in anything vaguely safeguarding. There's lots of things that need to happen. There are discussions with parents, obviously, sensitive discussions. There is further history taking. There is discussion with children's services, potentially sometimes with police, with my ward-based consultant colleague who was probably going to formally do the safeguarding assessment medical. And, by using ultrasound here, I was able to just very quickly expedite all of these discussions straight away. I rang the consultant upstairs as soon as I'd done the ultrasound and said, there's a baby who's, not walking, who's got a fractured skull. She came down, I showed her, we talked through it. She said, are you sure about what you've seen? I said, yeah, 100%. Because I'd been doing it quite a bit for trauma and for injuries. And, it was very unfamiliar to my colleague, but very familiar to me. So we got the CT scan and went from there. And we're able to have all of the other discussions in the background, saving several hours of time. I mean, I guess my worry is this child definitely could have been sent home because just a very minor swelling. It did not look like a bruise or an obvious boggy hematoma. There was no bruising, there was no abrasion, there was nothing. So then, of course, had a chat with the parents again, and lo and behold, a few mechanisms potentially came out of the woodwork following the past 2 weeks. And the child obviously went and had a full assessment, and nothing else was found in this particular case, thankfully. So yeah, so when clinical examination can only take you so far, this is when I'm typically trying to kind of look a bit further using POCUS, which I think it's really helpful. So this was an interesting 14-year-old boy who was in the PED, and again, this is copy and pasted from the notes. You can see what was written. He'd had some central abdominal pain with some vomiting, non-bilious, but then one was described as being a bit blacky brown. We see and hear that all the time, don't we? Usually doesn't mean much. Slight bit of coffee ground or discoloration. And then this was what was documented in the notes. It was going to be go home for D&V. And I came in the morning and reviewed, and he actually looked okay at the end of the bed. But again, I'll always take an opportunity to have a little look around at an abdo if there's any suggestion of anything going on before I send him home. So I did. So I put the probe on and got really unusual images for this child. So I'm happy to talk you guys through, or if anyone else wants to chip in, feel free to. So the first thing is what's really, really prominent are, kind of fluid-filled bowel loops, all right? So we can see a few different things. We can see spot on, excellent, yeah, agree. Small bowel, correct, totally. So we've got a few things, haven't we? So we've got, if here's our scale on the side, and this is 10 centimeters, this will be 5, this will be, 1, 2, well, 2, 5, that kind of thing. We know that these loops are completely fluid filled, which is unusual. Bowels normally peristalsing away, kind of collapsing, tiny little bits of air, artifact with little bits of free fluid, but typically not full and distended. And then we can see, got this bright posterior acoustic enhancement from all the fluid that's there. We've probably got, as the person in the chat has said, that we've got some interloop free fluid. It's probably not the kind of full extent of free fluid that we typically see in, ascites, perforations, that sort of thing, but we've got some really good examples of some interloop free fluid, something what we call a Tanga sign. You can just see it there, there's triangular little pockets of free fluid. And you can see here we've got some really quite big loops that are kind of maybe 5-6 centimeters in diameter or more. We've got quite ineffectual peristalsis going on for some of them, where we're not really seeing any movement throughout. We're just seeing a bit of toing and froing, possibly best seen, I think, a little bit in this clip at the start. And then we've also got a few other signs where you see these exaggerated mucosal folds around the bowel, and that's called the piano key sign, because these little protrusions here in and out of the sort of valvulae conjuventis in the small bowel here, it is meant to resemble that of the keys on a piano. So I said to the person who I was with at the time, who was one of our POCUS fellows, I just said, order me a CT scan straight away. And she couldn't believe, she sort of was looking at me really strange. One, because I never like to do any CT scanning. Anyone who's worked with me who's on the chat can say, unless it's needed. But number two, because this child looked fine. He did not have a big distended abdomen. He had not had profuse green vomits, but I knew at this point this absolutely was not just gastroenteritis. So this is also what I saw. So now we've got the high frequency probe with got like a bit of a virtual convex setting on it here, and so we do have some little pockets of free fluid, smaller amounts in and around. We've got some thickened bowel walls. We've got a bit of air artifact there, and again we've got some interloop fluid, but then some free fluid in and around. You can kind of make out, and then I had what I thought was quite a prominent loop here at the top, surrounded by some free fluid, and I thought I would definitely buy that to be an appendix. And outer wall to outer wall, I thought, yeah, probably saw an obvious appendix there protruding out of all of the nastiness. So the child didn't look great, but didn't look terrible. This is what I'd wrote at the time. It sometimes his anatomy was actually obscured by the bowel loops. That was what I was going to be saying at the start to you guys, that even in the right and left upper quadrants, most of what I was just saying was big loops of bowel, which would not be normal for the, hepatorenal space, splenorenal space. I think I'd measured one of the loops as 4.2 centimeters, which is decent for a child. And then again, some of the things I've already talked you through there, which I thought was an appendix at the bottom. So I said he needs a CT. He had some impressive bloods, which I don't think we would have picked up from him just clinically alone. Remember, this child was going to be sent home as gastroenteritis, so decent numbers. And this is his report. I'll let you have a little read, but we can see those prominent loops throughout. And so yeah, so this is how it was reported, and there was evidence of, at this point, perforation. So the child went to theatre and he did okay. So I think the kind of learning point of the pearl here is that, again, he as pediatric patients will, he by no means looked, severely unwell. Just to comment in the chat about the signs, yeah, Basker, that's fine. So the signs that you'd see for obstruction typically would be, there's distended loops about 3 centimeters, and they're normally fluid filled. And then, yeah, as the mucosal folds protrude into the bowel with fluid filled, you get like an interface between the fluid and the mucosal fold. So you don't normally see that, and that They're meant to look like the keys on a piano. So it's called the piano key sign. I've also heard it called the typewriter sign, presumably for the same reason. And then the small interloop free fluid triangle is called the Tanga sign, Tanga. Thank you. Okay, so this was a really interesting one. So I went to the ward to it's moving away from the PED slightly, but my colleague who is a PED consultant also does some time on the ward, spent some time up on the ward and doing ward weeks. And she'd had this child who had initially seen a PCD, not me, but it came in with just some central abdominal pain on and off, really for quite a while. It had been about 10, 12 days, but he'd been slightly worse. He'd had some diarrhea and some non-bilious, non-bloody vomits. And he'd had some initial blood tests when he first came in. See the dates there, and then we can see he'd been on the ward. He'd felt to kind of, be fairly non-specific, certainly not felt to be anything overtly surgical. He'd had a couple of different surgical reviews initially and then further down the line. And then, although his bloods aren't impressive, he'd had the sign that we don't like to see, even if you're not a big CRP kind of guy like me. Normally, when we admit a child and we start some treatment, I think at this point he had been covered broadly with some broad spectrum antibiotics. We'd normally like to see inflammatory markers reduce, wouldn't we? And certainly not worsen. So he wasn't doing great. He wasn't getting any better. So I got asked, could I come to the ward to do a scan because his pain was worse. The surgeons just were not convinced that he fitted with appendicitis. I thought, fair enough. And I went into his room, and he was with his mum, and he was really interesting. He was hunched over the table in his room, like the kind of table above the bed, rather than laying flat. He wasn't writhing around, but he was certainly kind of not the normal position you expect for something kind of intra-abdominal, peritonitic, maybe. And this is what I found with him. So again, these scans, just for anyone who's starting out, are just really grossly up straight away. They're just incredibly abnormal. We're seeing some really, really prominent kind of loops here that are, again, very static, similar to the last time that we saw that, sort of almost hyperechoic surrounding. We can see pockets of free fluid. We don't know what's happening here. Is this a loop of terminal ileum? Is this something else? But then, I mean, this one's the most prominent of all. It's an excellent, I really like this picture. It is a kind of, sorry, just keep that in the chat. I thought there was someone in the chat. I can only see Basker's comments. So if there is anything, just give me a shout. Feel free to speak up. So yeah, we've got kind of very, very echogenic hyperinflammatory fat wrapping, probably around one large loop of something there. All of this is a kind of a slam dunk for, this kid needs to go to theatre yesterday, really. I don't care how he looks clinically. This is, you need to take him. Yeah, very abnormal in many ways. But then when I had a closer look in the right lower quadrant, kind of slightly more towards his midline, and I remember this was one of the points that the surgical team were quite hung up on. I found this really interesting appearance here. So does anyone on the call, would anyone like to have a gamble at what kind of might be going on there? Just going to see who's on the call, actually, who forgot today. There's loads of people who could comment on this. Matt, if you're still around, you could definitely tell me what was going on here. Maybe he doesn't want to. So we're seeing clearly some free fluid. Okay, so this is kind of right down in the quadrant. Yes, you assumed what I assumed. Oh, I've clicked something, sorry. Appendicitis, sorry. Made my screen go all blue. What have I done? One sec. There, sorry. Now I've took the chat off. Sorry. Yeah, so I was clearly pushing for appendicitis. Common things being common, right? Probably with perforation based on the description of what this child had been doing over the last 2 days. The ward team were just so worried that he just was basically not being taken sort of seriously. I think the pediatric team were making the case to the surgeons. The surgeons felt he was atypical and not like normal appendicitis. And we don't live in that world anymore. I'm sorry, but we live in the world where people should be doing ultrasound, and that's a pediatric surgical colleague who's I'm going to be teaching next year on the postgraduate certificate where I did my initial postgraduate studies, who is of the opinion that we are not living in a world where we should be feeling the right leg fossa and ruling out or ruling in all appendicitis. Sometimes it can work. I agree with that. That's fine, but that's not the world of pediatrics that I live in, I'm afraid. So yeah, so this was a funny tubular structure that looked as though there was some sort of perforation had gone on, and this was either a collapsed kind of loop of bowel or something unusual. I couldn't be sort of certain. We're in the normal region for where the appendix would sit. We've got the iliac vessels here, artery and vein, lots of hyperinflammatory fat, lots of sort of, kind of a mental thing, that sort of thing. And I was like, right, it's tubular, it's unusual. I went and found the surgeon. I said, it's something. It's effectively appendicitis. I think it does look a bit weird. Um, so we had a chat, and he went to theatre, and this friendly surgeon was very happy to write in his op note that this was a Meckel's diverticulum. This was not an appendicitis. So the appendix was kept as it was. What I was seeing there was a Meckel's. So you try to find, and then obviously some free fluid as we talk about. So if we talk about Meckel's, it's really interesting. Any text you see will talk about as being the following: a fixed, non-compressible, there's a more hypoechoic here, structure in the shape of a cul-de-sac in the right leg fossa next to the anterior abdominal wall with this kind of a range, all right, from this page. So as you'll all be aware, those of you starting to look at appendicitis or are interested in learning to scan for appendicitis in the future, I know there's a few on the call, that is exactly what more or less how it reads for appendicitis as well, all right? So a blind-ended non-compressible loop of bowel. There are a few differences. And we can see here that you've got this sort of clear kind of outer wall, but then within you've got a bit more of a bowel-like signature with the mucosal folds. So obviously with this sort of Meckel's, abnormally persistent tissue of a Meckel's, that's much more classical of what you would get, as opposed to an appendicitis, which typically just looks like a very circular kind of outer submucosa, mucosa, and then a lumen without this floriate sort of floral pattern here that we see, and this kind of bowel fold. So I think now I've actually had two of these now. One in a boy, one in a girl. I think I would be happy to call it now, because you just get used to looking what an appendicitis, even if it's quite bad, can look like and can't look like. So yeah, I'd be saying this is probably, given that Meckel's aren't massively, massively rare, we do hear of them from time to time, don't we? I'd probably be happy enough to call this, but I try to understand how you could differentiate the two other than that, and there's not a lot, to be honest. So I think I've seen it for cases where I've not been involved with seeing a child go to theatre and have a Meckel's when it's felt to be appendicitis. So it was just really interesting, because the ward team felt like they weren't getting anywhere with him. He was kind of clinically not improving. He looked pretty bad when I saw him. I felt a bit sorry for him. Anyway, he got what he needed in the end, so that was nice. Okay, so this one was just a couple of weeks back. Trying to mix it up a bit with the cases, and I had a 12-year-old girl who just came in with left-sided cheek swelling. This isn't her, but it's very similar. Sort of looked to kind of be, kind of anterior superior to the mandible, as opposed to more where we see sort of good going lymphadenitis. She had no dental history. She was immunized, and I had a little look at her. And again, you couldn't really infer a lot from examination. It all just looks, pardon me, fairly big. But I had a little look over her parotid, because I thought, this looks as much like within the parotid as I've seen before, as opposed to, a submandibular problem. So there's a couple of approaches you can do for this. I've just started doing it over the last year, really. You can use any of your high frequency probes, and really you're looking for this triangular structure here. The parotids obviously sit on either side, anterior to the kind of preauricular region above the mandible. And then we've also got other salivary glands throughout. So we've got obviously a submandibular salivary gland, a sublingual salivary gland. And normally what we're looking at from superficial to deep, and depending which plane you're in, this is fairly homogeneous structure where, nothing particularly stands out. It's not particularly echogenic. You can obviously see the parotid duct, and you can see some vessels like the external carotid beneath it, not well shown in this view, but it should look unremarkable. Let's see what I've got here. Yeah, so I've gone for the parotid first. So this is what we've got. And just try and train your eye into looking at these top two images compared to this lower image, all right? So if you think of the scale of the screen, so we've got 3 centimeters there, 3 centimeters there, I haven't changed the scale. We've got here what I would be calling, I'll put my little smileys on, a nice normal parotid gland, all right? So well-defined walls, really homogeneous, not standing out at all, compared with the abnormal. these really, really unusual, heterogeneous kind of appearances. When it gets really bad, there's a sign called the pomegranate sign, where it's kind of lots of little circular hypoechoic regions and holes, but we can clearly see how unusual this looks. So this was the affected side, these two with a fairly nice lymph node through within it. So again, architecture-wise, this isn't looking too bad. It's got its echogenic hilum. It's still got a long to short axis ratio of 2:1, like a bean shape. That's what we want. But it's pretty decent in size. That would be probably about 2 point something by about, 1 point, about 1 point something. So even a short axis ratio of 1.1 or something like that. Sorry, short axis measurement would be quite a lot. So it's like a good going lymph node. But we only had a few of these. We didn't have a lymphadenitis to call this. So they're asking me, is this lymphadenitis? And I'm telling you, well, sorry, this was the MaxFax team, the ENT MaxFax team, had scanned it and asked them to come. And they sort of said, she's immunized. This doesn't seem like mumps and whatever. And I just said, yeah, but what I'm telling you is it's the parotid. So they're asking lots of questions about, is it not lymphadenitis? Is it not infected thyroid glossal duct cyst? The consultant had called as registrar of the board and actually asked, is it not just a cystic hygroma? And I'm thinking, well, they're completely going off on a tangent here. It's got nothing to do with the cystic hygroma. It's got nothing to do with thyroid glossal cyst. I've seen the parotid. It is the parotid. So she turned out to be mumps. Oops, sorry, click that. Didn't mean to click. Have you seen a fair amount of yeah, so it's interesting. So we saw it takes quite a long time to get the IgMs back for the mumps. I can't say I'm brilliant at following them up that well, to be honest, but you're absolutely right. What I was able to do here was just tell them, we don't need to have any more discussions. It's the parotid that's the problem. Look, you can clearly see the difference, and they had a good look at the scans. We agreed. It's tricky, isn't it? Because we see so much lymphadenitis, we see so much stuff that we recognise really commonly. But if someone isn't familiar with what you're seeing on the scan, and I guess how certain you are of your findings in terms of which anatomical structure you're looking at, it can be really hard to get your message across to them, really. So yeah, we did all of the usual baseline viral serologies. But yeah, Mum in this case was just more worried because they were going on holiday the next day. Here's quite a nice colour flow pattern, which we don't always get this as well as this, to be quite honest with you. But I'm sure you guys who are all starting to get interested in ultrasound and do some stuff, you're aware of what we should be looking at. So here we've got external carotid vessel, bit of flow there, a bit of aliasing or bidirectional aliasing flow there. But yeah, nothing within the actual unaffected gland. Whereas on the abnormal one, we can see again, look, it's much bigger than the other one. And then can see this beautiful enhancing color flow pattern throughout. So that in the same way that a reactive lymph node becomes similar to that, we can clearly see the sort of unusual pattern and enhanced flow. So that was nice. So yeah, that was a nice case. And then again, just another example of the sort of well-defined borders, very smooth and homogeneous versus the very heterogeneous. Okay, move on a little bit. So this was not too long ago. A few weeks back, a little 8-year-old girl had been doing a trampolining session. She'd sort of jumped up and kind of gone onto an outstretched hand and had pain and swelling and kind of that lovely purplish bruising you get mid clavicle. So I said, yep, it's going to be a fractured clavicle. We're going to put you into a sling. You don't need to worry. We followed you heal really well. You'll be fine, kind of thing. Yeah, someone on the call remembers exactly the night we did this. And I said to Mum, it's fractured. Don't worry. We'll have a look at it on X-ray. And yeah, we can see here. So hopefully everyone's, PEM-minded people are happy looking at a normal clavicle and its report. And, you get this undulating pattern, even on ultrasound, you've got to follow it deep, just superficial, just deep to the skin. And it moves, but I can assure you, me reading this as an X-ray, that's all totally normal. It's just one of the angles you get. And the radiologist agreed. And I just said, nope, not a chance. And of course it was fractured, it's about as clinically and obvious a fracture as you've ever seen. And these were the pictures we got. So, bony cortex, we're only literally 3 or 4 millimeters beneath the skin, really, before you start to then pick up the clavicle, and following it can be tricky. You keep it in view. So there we go. So I said, no, honestly, it's fractured. So we put her into a sling, it was fine. And then we got a lovely little letter in trauma clinic who said, yeah, it was either a sprain or it was a soft tissue injury. All of those well-known soft tissue injuries that you get over the clavicle in that age group. So anyway, she was in a sling and she was fine, and I told the mum just to keep the sling on. So yeah, so we've got a couple of examples of these where clavicles can be a bit tricky. This was another one. This girl had had a fall at nursery, and she'd had these initial X-rays reported as normal. She came back to my trauma clinic 72 hours later and was still tender, not using the affected arm on the right side. And this is what I found. So she was the medial third. So the, oops, all right, that's a picture. So this is the medial aspect with the articulation, obviously, of the kind of manubriosternal joint, kind of clavicle there, and we can clearly see the fracture. I think if you really look back on the X-ray, you can just about appreciate. I think, sorry, I'm trying to look on my small screen. I think it's here somewhere. I've subsequently gone back. You can almost just see a slight angulation, but not as nice as this. And you show this to a parent, and I think they feel a lot happier because obviously they've been told by 3 or 4 different people now that it's normal, and that they know the child's still in a lot of pain and isn't normal. So I think it's always worth bearing that in mind. That it's a benefit for them to see it as well. And this was in clinic as well, different day, and I was asked by a colleague, could I have a little look at a foot? So this is a 5-year-old boy who'd been in his bedroom barefoot and had felt like he'd stepped on something sharp. Could I have a little look at his foot? I said, of course I will. Not doing anything better. So came along, and he'd been seen once and presented with some pain, painful weight bearing. And then that settled down a little bit. He had been back to an urgent treatment centre within that same week. I was also reassured that it didn't look too bad. And then 31 days later, he came back with a funny red thing on his foot, having probably just tolerated the pain. And this is what he had on the sole of his foot. This is his foot, lateral border. And these were his X-rays. These were his second set of X-rays. So we've had 4 views now in total from the start to finish. Nothing that I can particularly pick up on. So I had a little look on POCUS. So we're having a look, we're not really in a long axis here. We can almost just see this end on kind of thing, but even as a transverse, as an end on, this is a decent enough size. This is probably that's probably 0.5 centimeter or more, which for a foreign body is pretty big. You can see the surrounding kind of hydroma, the sort of fluid formation around it. This is really classical of a particular foreign body. And then these were the crazy views that I got when I looked at it again in a long view. So I couldn't believe this case. I mean, even this alone in oblique, it looks enormous, but here we can see from there to there, there to there, nearly 2.5 centimeters long, which is, it's a lot longer than you think. I'm going to show you what they pulled out of his foot. And it was this thing here at the bottom. So you can appreciate how big these surgical scissors are, the ones in theatre. And we can see how thick and massive this piece of cocktail stick is from a, barbecue skewer, probably better way of describing. And yeah, luckily we're able to show the ortho guys, look, this is what he's got in his foot. It doesn't matter what this shows. This is what he's got. Please, could you take him to theatre? Because I think he needs to come out. And they did, which was great. The parents were really grateful. So this was a 9-year-old girl, and this was one ED. Again, I've spoken about this case before, so others might have heard me mention this one. And this was about 2 years ago, I think it was now, when we were right in the height of the kind of so-called strep pandemic crisis in the UK, where everyone thought strep was a major problem again, and a couple of invasive cases had occurred across the UK, and it became a media storm, I guess. And I'm sure everyone else can remember in their own departments, but we were sometimes full to the brim on an evening with children who may have had sore throat, who parents were really worried. And at this point, I think we had 72 patients in our department, which was crazy amount for our department. And this girl came in, she was in one of the high dependency rooms. She'd been at ballet, she'd done a twist, and it was later at night by this point. She'd heard a crack and she couldn't move a leg. So I thought, right, she's definitely got a fracture. Could well be a femur the way she looked. She looked pale. She didn't look great, to be honest. So now my concern here is that even with intranasal fentanyl, she still wasn't kind of stable. She wasn't pain-free enough. She wasn't settled enough to be able to get around to X-ray just to image the leg. I would have needed to have undertaken kind of at least one ketamine sedation, straightened her up, got her into some form of a kind of temporary splint, got her to X-ray, got her back, then definitively sort out to do, sort of plan for what to do. So I had a look with ultrasound, which I always will after examining. So we've got the different kind of quad muscles, either sort of vastus lateralis and rec fem, but basically you've got the two muscles there, and we've got this beautiful glinting fracture, two pieces of the bone, and with a nice kind of hematoma, a bit of intramedullary marrow, fat and blood around it. Subcutaneous tissues there. And then in transverse, we're looking down at this circular semicircle pattern of the femur coming down in like a CT scan would. And it should be a perfect circle like that. But you can see at the starting point where I start, it's broke. There's the kind of cortical deficit there. There's the sort of step. And that's how it should look there at the end. And that's how it looked in the middle. So I said, yeah, it's a fracture. It's 8 centimeters away from the joint space. We don't need to do anything else now. We just need to put in a femoral block, which is what I'll do. So I won't labour over this too much. For those of you who've done it, I was obviously doing ultrasound guided femoral blocks. We've got our vessels, artery and vein here. We've got a hyperechoic triangular femoral nerve coming in there with a needle well out of the way through the fascia lata, fascia iliaca, and enveloping this nerve there with local, keeping well away from the nerve with the needle tip. And it was great because when I went back in, I think the more of these you do, the probably better at them you get. Or if you teach them, and I probably did some in my early days that were much less effective, where I'm keeping well away from the different fascial planes, and I'm maybe not enveloping it the way I would want, and you're just doing, I guess, what a lot of our other colleagues are doing, where they're kind of some are using ultrasound, some aren't, and anyway, I've done some that were less effective than this one, and now I think I've probably got a better kind of way of doing it. And when I went back in, she was singing nursery rhymes with a nana, and I really remember it. And she was smiling. She looked great. She looked pain-free. So then finally, I got some X-rays. Once her Thomas splint, which is there, was on. So I didn't move her from the department. I didn't need to kind of do different sedations. I couldn't have done a sedation because the department wouldn't have allowed for it in terms of staffing and safety levels. It would have led to, it would have been a safety sort of risk. So we did it all within 5 minutes under ultrasound, and that's what she had. And then just to finish up, we've got some more examples of bones that can look a bit dodgy when people fall off the skateboard, and they can come into like this. And I like to, if we're doing any manipulation and then some casting, we often in the room keep an eye on the patient from a support perspective, if they're having fentanyl and Entonox, or if we're actually giving, if we're going to be doing it under, pardon me, ketamine sedation, we'll be there at the top end doing it. So what I've started to like to do is to get the ultrasound images there from the start, looking at the angulation there for maybe about 35, 40 degrees there, to checking the manipulation with ultrasound, which is bang, nice and straight and perfect. Because we've all been, don't know if any adult doctors on the call, but there are lots of examples where we've all done manipulations of wrists and different things in the past, and we think that clinically they look really, really good, but actually in reality they don't look any much better than they did at the start. So I've started to look under ultrasound. We've got a few examples of that, and there's the picture after. So with my cases today, we're sort of in the territory of, well, so what? Hopefully it's been convincing enough that these are the reasons why I think ultrasound have played a massive role, when normally these children could have all had quite different management. So presumably it's not kind of the people attending these talks who need any convincing on that. But if anyone does have any questions or queries they'd like to double check, please do so now. Happy to talk through them. And then I just always like to end on this this slide, sorry, for any talk I give. Would anyone like to ask anything or check anything, or happy to answer any questions if so? Where do you measure your angulation? Yeah, I mean, I guess in 3D you would be, when we're doing it on X-ray, would kind of come through in transverse, would come through the sort of mid physis and would come through the mid, I guess the midpoint of the bone, to give the greatest angulation here. So try and give an example. So here we're talking kind of through the middle of the bone, intersecting both cortexes to give the kind of dorsal angulation, which here's not a lot there, pretty good. Here we're looking in a slightly different plane, aren't we, Nigel? We're looking level in long section with the kind of longitudinal axis of the cortex, so we can see the proximal fragment and the distal fragment. So it's slightly different probably to the view you're getting on X-ray, but taking the 3 views we normally do, which would be a kind of a dorsal, an anterior kind of ventral palmar approach, and then a lateral approach. All measurements, well, not all of them look the same angle because obviously some of them are end on, but the 2 of those views are likely to give you kind of the same degree of angulation. So I think clinically here, I'm probably not actually measuring really. I'm just going, okay, this is super wonky. There's the point of the kind of the kind of compression side of the fracture. There's the kind of 2 fragments, and then how straight can we get this after in the same plane? So I'm looking normal. So it's probably not the same way an orthopod would measure it on an X-ray. We're just doing it kind of, we're doing it kind of more gross estimation, I guess. Sorry, chat's gone off. Is there time we can please recap fast positive trauma cases you discussed? You joined late, Pascal. Yeah, I'll quickly talk through it. And if other people have to leave, that's no problem. Sorry, I ran over a little bit. We were just waiting for people to arrive. I don't know if there were 2 different links or something, but we'll normally start about 1:05. But anyway, thanks everyone else who's attended today, and hope you found it useful.